Surgery in newborns. I have talked about the importance of prenatal diagnosis of many of these surgical defects. I have talked about bedwetting, and now I am going to talk about understanding and treating major urological. By urology I mean the entire genitourinary system, which consists of kidneys, ureters, bladder, urethra. So many times what happens is, what we have seen is that though there are major urological problems in the child, very often they may have a very non-specific presentation, which is why it is neglected or ignored. They may have a presentation of a minor nature. It may be totally silent. See, the problem with children is they are not able to vocalize very often. They are not able to tell like adults can tell that, okay, I have a pain in the loin, I have a pain in the abdomen, I have a problem in passing urine. They cannot tell us. So we have to guess, or the parents, especially the mother, has to be very observant that yes, when he passes urine there is a problem, or he strains to pass urine, or he is discomforted when he is passing urine. Any of these are small points to us, but they may be a pointer. There may be a complaint which is totally not related to a urinary system, like fever. Fever very often is there, and we always nowadays say malaria, dengue, all these things. Nobody does a simple thing like a urine examination which will show urinary infection, which is the cause of the fever, and therefore we go to other things. I will be showing you in the course of this next 30-40 minutes actual patients who have come, what are their complaints and what we have found because we have investigated. Because many times you may lead to a wrong diagnosis and then you have missed the bus. See, now some of these simple ones like urinary infection, it's a small thing which occurs in, like we have respiratory infection, but we treat the cough, cold, fever and forget about the child. But in urinary infections, you should not forget about the child. Treat the child, yes, but after that you need to follow up, investigate. Abdominal pain which is recurrent, it's a very non-specific thing. Now if all children get abdominal pain, now should you start doing tests in each and every? That's where the clinical judgment of a doctor comes in, whether the history, what is the history, what are the examination findings, and then do the relevant investigation. You might come up with problems in the urinary tract. Though the pain is in the abdomen, you assume that it is to do with intestines or liver or something. It may be to do with the kidney and the ureters. Abnormal voiding, passing of urine. Again, you can get major problems with just that small thing. Incontinence and enuresis. Child is not able to hold urine properly. Now you start wondering why it could be. And if you don't properly investigate it, you might miss a major anomaly. Just an abdominal distension, bloating of the abdomen, you don't know what is the matter unless you investigate. Fever of unknown origin, as I told you, it's just fever. You may think about malaria, dengue, influenza, but you can also think of urinary infection, which means eating or drinking well, not putting on weight in spite of all the medicines given, etc. And you start wondering why is the child not doing well. One of the reasons could be an undetected urological problem. Difficulty of straining to pass urine. Very often they come with that. Most of the times people think circumcision is to be done and that's all to be done. No, there may be something much more dangerous inside the child. And such kind of things are there which can cause. Just to give you an overall, that there are normally two kidneys which are the manufacturers of urine. The pelvis and the calyces are the collecting system which goes into the ureter, and both the ureters open into the bladder, and from the bladder is a single urethra. Now this will be useful when I talk about other things. One of the many names that are randomly thrown about by doctors, by sonologists, is hydronephrosis. Now hydronephrosis simply means dilatation of the collecting system of the kidney. It does not mean necessarily that dilatation means there is obstruction and therefore there is an obstruction in this child, which is why the child has had hydronephrosis. No, it can mean multiple things, but hydronephrosis is what we must know about. So what is hydronephrosis? It can be progressive. This is the normal kidney, this is the manufacturing unit as I call it. of the kidney. This is the collecting system. Now if there is an obstruction somewhere here, what happens is the kidney starts accumulating the urine, and as the urine starts accumulating, the collecting system starts dilating, so hydronephrosis goes on increasing, and with the result that this manufacturing unit becomes thinner and thinner and thinner, so that in very severe cases you can get a very thin renal parenchyma or the renal manufacturing system, which is why you need to relieve the obstruction before this occurs, before the kidney is badly damaged and irreversibly damaged. Now again, as I said, hydronephrosis is just a technical term. It can be because of obstruction and it can be without obstruction either. I am not going to go into those details, but whenever a suspected hydronephrosis is there, these are some of the tests. Not all these tests have to be done in all the children. I am just giving you a list. Sonography, micturating cystourethrogram is where we pass in a tube into the bladder, fill up with a contrast and take an X-ray. While the child is passing urine, we take an X-ray. After the child finishes passing urine, we take an X-ray. This is an excellent investigation for the lower urinary. So you can see the bladder, you can see the urethra, and you can see whether the bladder is completely emptying or not completely empty. IVU has been largely replaced by CT and MR urography, where you look at the complete anatomy of the kidney, like how big is the kidney, how small is it, how is it functioning to a certain extent, what is the size of the ureter, what is the size of the pelvis. It gives you a very clear-cut idea. And radionuclear scans are mainly for function. There you inject a radionuclear material and then you see how the kidney is functioning. Like normally there are two kidneys, so each of them should be 50-50%. Now in an affected kidney, if it is badly affected, that 50% can go down to 22, 3, 4% or even 45%. So based on that, we know how badly the kidney is affected. Automatically the other kidney will show higher function because the total has to become 100. So if one is at 20 and the other shows 80%, don't think that kidney is a fabulous kidney. It is just doing overtime to compensate for this kidney's bad performance. But this kidney which is showing 20% is not a good sign. Anything below 40% is considered as not such a great idea. Now see, ultrasound will show this dilated. Now if it is dark and dilated, it means it is fluid. So fluid filled hydronephrosis means it is more of a collecting system which is now dilated. Again, now a 2-month-old child was brought with a complaint of just abdominal distension. When I examined, I felt a lump. There were no urinary complaints. The child was passing urine regularly without difficulty. Otherwise, very healthy looking child, except that slight mild distension, and I could feel a lump. So we asked for a sonography to see where is the lump coming from, which organ is it coming from, is it full of cyst or full of liquid or is it solid. All these things can be basically cleared up by a simple ultrasound.
Lump in which area?
In the abdomen here. Correct. So therefore when we did the ultrasound, we saw this, which was the dilated pelvis. It was from the kidney. Something like this must have been there in the child. So this is classically known as a Mickey Mouse appearance. It looks like Mickey Mouse 2 ears and the face of the Mickey Mouse. So it's just a way of making people realize what you are looking for. But this is a classical thing of a hydronephrosis, suspected obstruction. For the obstruction, whether it is or it is not, and the function, we have to do what is known as radionuclear scans. Now they will give you two things: differential function, that means is both 50-50 or not, and how much retention of the radioactive contrast in the pelvis. Normally it collects and it drains down into the bladder. Now if at the end of 30 minutes large volume is still up in the pelvis, that means it is not going down, that means it is obstructed, therefore it needs correction. So in this case we did, see the child's name was also not kept still, it was baby of Shilpa, and at 3 months when we did, the function on the right kidney was only 38% instead of being around 50. And number two, at the end of 30 minutes on the right side, the retention was all as high as 90%. That means only 10% was going down. Whereas if you see the left kidney, only 31% was remaining, which means almost 70% was going down. So in this case, 90% of the urine was still up in the pelvis, not draining down. Obviously, it meant there was a severe obstruction. So the obstruction is somewhere here. The surgery is excising that part which is abnormal and joining the normal to the normal so that you get a proper drainage. Now, this is obstructive hydronephrosis, where longer the obstruction exists, the more the back pressure. Like you can see here, this is less, this is even lesser, and this is very less. So if you catch a child at this stage, the recoverability is going to be much less than if you catch the child at this age or at this point in time. So therefore it is very important that you do it, and which is why, if you remember when I was talking about antenatal diagnosis, ultrasound and early pickup, that is the difference. If the obstruction is relieved early in infancy, the recoverability of the kidney is far better than if you do it after 1 or 2 years. And this is there from before birth. This is not occurring after birth. So even if the child is 3 years old and you find this problem, it is not 6 months ago that the whole problem started. It has started from before birth and it has continued. We have not been able to pick it up for whatever reason. It's not that this has occurred recently. Now this is exactly how it looks in the lying down position during surgery. This is the kidney, this is the dilated pelvis, this is the distal ureter which you can see. This is where the obstruction is. So we need to excise from here to here and then join this to this to make it a clear thing. And this is when we are just about to join the last part of the anastomosis. Now this was a child which was discovered accidentally by the parent while giving a bath, and they found there is a lump, and they said, I don't know, I felt a lump, they are not sure, etc. So they took their time, but still they came back to us. We did an ultrasound, it turned out to be a hydronephrosis with obstruction, we operated. But there was another child who was brought with a similar lump here, an older boy about 6-7 years old. But this was not looking soft. When we did the ultrasound, it was a solid mass arising from the left kidney. And when we did a CT, we realized that it was a cancer of the kidney.
What's the age of the child?
7 or 8 years old. And this was that whole mass which was from the kidney itself. So it was a cancer of the kidney which was picked up at 7 years. Because there was a lump, we felt the lump, investigated the child. Otherwise the child was not really having pain or anything. Just because of a lumpish feel that the parents brought it to us, we got a CT done. It was a huge thing. We had to remove the entire kidney. There was no other option. And give him chemotherapy later on. Child has done fine. But we caught it early. The parents brought the child to us early. Therefore we were able to give good results. If the parents had tried allopathy, homeopathy and other Ayurveda and all these things to decrease the lump, this would have grown, this would have metastasized, and by the time they came to us, we would have said, sorry, we will try, but I am not sure whether we will be able to do anything much. Now, we were talking about obstruction. This is another thing where if these are the kidneys with the ureters opening into the bladder, normally kidney forms the urine, it goes into the collecting system, it flows down into the bladder and flows out. But in some children, the bladder urine goes up, which is called vesico-ureteral reflux. So it can go up on one side, both sides, and there are different grades. So reflux is again another phenomenon which is present from before birth, does not occur after birth. So irrespective of what time you see these patients, the process has started before birth. You have caught it so late. In fact, in the 80s, in United States, almost 20% of all renal transplants were because as children they probably had both sides gross reflux, which was not diagnosed and therefore not treated, and therefore the kidneys were damaged and they came up for transplantation because both the kidneys were damaged because there was reflux on both sides. So reflux can give rise to bilateral or both kidneys failure, and then transplant is the only way to go forward. And so it is more important that we catch them as early as possible so that we can start the treatment. Not all of them require surgery necessary. What we are going to do is prevent infection. It is the infection with the reflux which can damage the kidney, which can lead to renal failure, which will ultimately lead to a renal transplant. Now, even in a non-symptomatic child, it can be as high as 18% of non-symptomatic children may be having reflux on one or both sides. Those who present with urinary infection, see again am I telling you, simple thing like urinary infection, we tend to treat it, which is correct, and then forget about it. No, almost 50% of them may be having reflux, and the only way they present to us is with the first urinary infection. If you don't catch it that time, if you don't follow up, if you don't investigate, they will go back, get more infected, again come back with a urinary infection. By that time the kidneys have been started to be damaged, and then you have late. And therefore it is important to, now this is what I am saying, now in MCU or what I was talking about, we fill up the bladder with this white contrast, and when the child is about to pass urine, this is going up, this is not coming from above down, this is going, there is dilatation, see. Now this is also hydronephrosis by definition, because there is dilatation of the pelvis and of the ureter, but it is not because of obstruction, it is because of gross reflux. And therefore again, hydronephrosis is a non-specific term. It does not necessarily mean obstruction. It could be reflux, or it could be obstruction, or it could be neither, but still there will be. See, the normal reason why reflux does not occur is because there is an oblique entry. The ureter does not open end on into the bladder. It opens like into a tunnel, and the tunnel ratio is about 3:1. If the diameter is 1 millimeter or 5 millimeters, then the tunnel length has to be at least 15 millimeters. So therefore that prevents reflux in normal children, but in those who have reflux, they open without any of these tunnel, without proper mechanism, and therefore reflux may occur. Again, there can be primary, where there is abnormality of the opening of the ureter into the bladder, or it could be secondary to something like distal obstruction. Because there is obstruction for the urine flow from the bladder outside, the back pressure hits the ureters and opens them out and allows the urine to go up, just to take away the pressure from the bladder. But what the bladder gets relieved, the pressure goes to both the kidneys and destroys the kidneys if not caught in time, if infection goes up. All these things have to be taken care of by us. Now this is what the classification of reflux is. If the urine rises only in the ureter, ureter plus system, ureter plus calyx and the pelvis, but mild dilatation, gross dilatation, and this is grade 5 is the ultimate, where the urine actually hits the kidney itself, the reflux with the pressure. So the worst is grade 5, the best is grade 1. So therefore you need to pick up whether it is one side or both sides, whether it is grade 1, grade 2, grade 3, grade 4 or grade 5. Grade 5 has the worst prognosis, grade 1 has the best prognosis. How do they present? Simple urinary infection or urinary infection with fever. Urinary infection and fever, our antennae have to go up. Do not take this casually, especially in an infant, that means less than 1 year old. If there is fever more than 100, urine shows infection, very dangerous. Do not take it casually. Many times we advise them, get admitted, we will give you intravenous antibiotics. Because if there is reflux in this child and we do not treat the infection aggressively, that infection can damage the kidney. And in this case, if it is both sides, it is going to damage both kidneys. If it is one side, it may damage one kidney. Fortunately, the other kidney may be. Burning urination, painful urination, again non-specific thing, but unless you follow it up, you will not pick up reflux. Foul smelling urine, again classical of a urinary infection. The parents will come and tell you, doctor, he's got very foul smelling urine. Said, get the urine done, see that there is infection, start antibiotics. Young infant which is not thriving well, not putting on well, not taking feeds properly, not really body nathi thati, those type of things, that you should look for a urinary infection, or it can be suspected on an antenatal ultrasound. Again I am coming back to that. That's a subject very close to my heart. People have not yet accepted or want to realize the importance of prenatal pickup and counseling. Picking up can be done by the sonologist, but beyond that they do not counsel. We sit down and counsel the patient what could be the possibilities after your child is born. What are the effects of reflux which is not treated? One, recurrent urinary infections, renal scars form. That means where the damage occurs to the kidney with the infection, that part stops growing of the kidney. Remaining grows, so there is like a pit. So that is called a scar. The renal growth as a whole can stop if it is severe. Renal function starts following. If it is one side, it's alright. If it is both sides, both kidneys start dropping. Hypertension is another complication. And somatic growth, even the growth of the child gets stunted because the kidneys are damaged. So these things are the effects of untreated reflux, and therefore the importance of picking up and starting treatment for reflux as early as possible. Now the options, surgery if required for reflux. In few cases we need surgery. They can be through opening the bladder, it can be without opening the bladder, it can be a combined, it can be through the endoscope by injecting, or it can be through laparoscopy. Now this was a child where both the ureters had to be reimplanted because both were refluxing. Therefore we have to take them out from the original, make a new tunnel, and then stop the reflux. Now this is an open bladder. This is from the urethra, it has come inside the tube. This is one opening where the ureter comes in the left side. This is where the right side ureter comes in. We have to now do both the things at one sitting. We cannot do one ureter, then come back after 1 week, do the second ureter. No. We do both the ureters at one sitting. See, from inside only we have dissected the ureter completely on one side, then on the other side. Now see, this is dilated slightly compared to this. Now what we need to do is remember that when we make a tunnel now, we have to make a tunnel which is 5 times the diameter. So if this diameter is 10 millimeters, we need a 50 millimeter tunnel. And tunnel we make with a scissor below the mucosa of the bladder and then pull the thing through on both sides. Similar tunnels, we make separate tunnels for both sides, bring it through and keep a stent. Now this is major surgery because probably there was gross reflux, there was scar, there was complication, which is why we had to go in and do the surgery. See this child, he had massive unilateral reflux, and this is the post-operative of the same guy. There is no reflux on either side, which means you know that we have done a good job. Because now what reflux was there, which is almost grade 4 or 5 in this child on the left side, when we did it after surgery, there was absolutely no reflux, which means we have done a proper job of fixing the ureter and putting it in a new place. Now again, coming to ureters, there can be what is known as partial or complete duplication. Partial is that there are 2 pelvis and 2 ureters only up to a limit. It can be finishing here, it can be finishing here, the 2 can meet here, but ultimately there is only 1 ureter opening on one side, 1 ureter opening on the other side. Now this child was a 7-year-old boy who was brought with pain in the left loin for the last 10 days, high fever last 20 days, no rigors or chills. He was as usual looked at for malaria, etc. It was ruled out. What we noticed while clinical was that there was a redness in the left flank. So we suspected that this has probably something to do with the kidney. We got the ultrasound done, it showed a huge dilated pelvis of the kidney on the left side. But we were not happy with the whole thing, so we got a CT urogram done, which showed that there was a duplication. So the duplication was clearly seen here. There were two ureters, two pelvis, but we could not see it below. See, now this is the vertical scan, where this is one pelvis and this is the other. See this? This is a smaller pelvis on top, this is a larger pelvis on below. This is hugely dilated, that is not so hugely dilated. Just to prove our purpose, we did an intravenous urogram, where you can see this is the big dilated pelvis, this is the second pelvis on top. You can see two ureters, this is one ureter, this is the other ureter, but below we could not make out. So, but when we put in a cystoscope from below, we found only one ureteral opening on the left, one on the right. So we knew that this was not a complete duplication, it was only a partial duplication. So when we operated, we found that there was exactly that hydronephrosis, pelvic and ureter junction was obstructed here. This was one ureter going down, this was the second ureter from the upper pelvis going down. But when we traced it down, we found both of them were joining here, and there was one ureter which was opening into the bladder. So this was a partial duplication. So the problem was obstruction at the upper end, which we operated and got rid of the bad segment and anastomosed the normal to the normal. But there can be a complete duplication. Now complete duplication means there are two parts of the kidneys, two pelvis, two ureters, each of which is opening separately in the bladder. So ultimately the bladder, instead of having two ureteral openings, has three. If there is one side duplication, if there are both sides duplication, you will have four. But again, with the duplication, there are other anomalies which are there. It may be only duplication, or it can be duplication with a ureterocele, which is like a balloon inside the bladder, which I will show you. And therefore we need to tackle all these things as a whole and not as an individual. See, this is the upper pelvis, the upper ureter, this is the lower pelvis, lower ureter, side by side opening separately, and this bulging like thing is the ureterocele, which means there is complete duplication with a ureterocele. This is another classical thing where you can see the bulge inside, and because there is a bulge, it is narrowed and therefore it is obstructed. Because it is obstructed, this is dilated. But the other one is not obstructed, but usually is refluxing. So we need to do surgery for both, because one is obstructed, so we have to take away the obstruction. The other one is allowing reflux, so we have to stop the reflux. Otherwise this kidney, this lower part also will get affected, may get damaged at a future date. 7-year-old boy, recurrent urinary infection, failure to thrive. He was not doing well, he is not eating properly, he sometimes complains of pain, he is not comfortable, these things. We got a sonography done because of urinary infection. There was a ureterocele, see that bulge you can see here in the bladder, and dilatation of the upper parts. So we knew that there was a ureterocele, probably with a duplication and obstruction. So when we did the IVU, you could see two pelvis, two ureters. One of them was dilated right here because there is an obstruction of the ureterocele. So one was dilated because of obstruction, the other one was not dilated but was having reflux. So we had to fix both of them. See, this is the one which is refluxing. The first one which I showed you was the one which was obstructed, therefore large ureter. This ureter is not dilated but it is refluxing right up to the kidney. So therefore we had to fix both. So for the ureterocele, we put in a scope and incised, just cut the ureterocele, so we relieved the obstruction. This dilatation went away, and after 6 months we did double reimplantation of both the ureters into the bladder, and subsequently the child did perfectly well. He has started eating well and he has done well in terms of things. See, sometimes recurrent urinary infection in a girl, duplication on this side. See, again we have to treat for obstruction as well as for reflux. Or in this case, what you are saying, both sides there is duplication. This is 1, 2, this is 3 and this is 4. 4 ureters, 4 pelvis, 4 types of kidneys, and we have to try and preserve each and every one of them. There is no kidney which is expendable, you can take it out. And this is where we come to again a 10-year-old boy who came to us as an emergency. He had an accident. He was riding a bicycle, he fell off the bicycle, and then he passed a huge amount of blood in his urine. And that was the only thing. So we assumed that because he has fallen and probably hurt himself and the kidney must have been damaged and therefore the bleeding from the kidney. But when we stabilized him and got a sonography, his kidneys were perfectly alright. What we found was a huge bulge in the bladder, and that was a uretrocele. Now he is 10-year-old. The uretrocele is there from before birth. It has not occurred recently. And then when I asked his grandmother, because his mother probably was not so well known to him, the grandmother was able to say, he used to have some difficulty in passing urine. And when we did the surgery, look at this bulge. This whole thing is a uretrocele inside the bladder which was sitting there, and the child was totally not symptomatic. And only because he had this bleeding after the accident and we did an ultrasound and we saw this, that we thought this is the problem. So there is a uretrocele on one side with a duplication. So this is the normal one on the right side. This is the uretrocele with an opening right here on the left side. And when we looked here somewhere, we found a second opening of the ureter behind that uretrocele. So we had to remove that uretrocele and dissect out both, and that's when we realized that he had 2 ureters on the left side. The right side was perfectly normal, but the left side had 2 ureters. Both of them had to be fixed. One was obstructed, the other one was refluxy. Then there is complete duplication, but there may not be a uretrocele. It's just complete duplication, no obstruction. But again, they may come with a problem. 3-year-old girl, pain in abdomen, pain in right flank, dysuria, difficulty in passing urine, mild fever, vomiting, some amount of enuresis. When we investigated her, we found that there was duplication, complete duplication, but no obstruction. But because there was duplication, there was reflux, therefore we had to operate this child and correct her problem. See, you can see both the ureters running parallel to each other. One is slightly more dilated than the other. And this is the classical case whom we had picked up in 96 December antenatally to have a dilated kidney, and we found that there was a duplication. See, the upper part was also dilated, lower part not so dilated. We had picked this up before birth, so we investigated her soon after birth, and within 1 year we had finished 3 surgeries. This was in 96. See, this is how the ureter looks. This is the dilated one, which is the upper one. The lower one is not so dilated. Now this is the one which can be done. We did that. We did the MCU which showed reflux into the non-dilated one. So this side one was having reflux, and this was showing obstruction, so it was dilated. So we had to temporarily, at newborn stage you cannot do this major surgery of taking out the ureters and pushing them into the bladder when the bladder is so small, you don't have enough space. So we had to make this come down to normal. So temporarily we just had to remove the ureter on the outside and let the urine drain. But that took away the obstruction, therefore this kidney could survive. And afterwards we did a reimplantation of both the ureters, and then we closed this ureterostomy which was temporary. She had come about 3 months back. We got her radionuclear scan done, the right kidney was showing 49%, the left kidney was showing 50%, 51%. So the only reason why we have been able to save her both kidneys was purely because we had picked it up before and started treatment immediately after birth. Now this same child, had she not been picked up at the birth time, she would have come to us with gross infection because of the obstruction, and we would have probably landed up doing a partial nephrectomy, taking out the upper part of the kidney which was infected and badly damaged, trying to preserve the lower kidney, and she would have been in a mess. Because we had picked it up early, we were able to give her a complete cure. 11-year-old boy, just dysuria, straining to pass urine and recurrent urinary infections. We got him investigated, we did the ultrasound. This is the bladder, but this is something which is coming out of the bladder. So we did the MCU where it showed this is the bladder and there is a small pouch. We waited, and what happened was the bladder, and there was a huge diverticulum behind it which got filled up. So where the urine was accumulating, stagnating, this is the urethra as he is passing urine, which is perfectly normal. So this was the problem why he had infection, because the urine used to stagnate in that diverticulum, not get emptied when he passed urine every time. Some amount remained. That gave rise to infection, which was giving him problems. So we had to go in this is where that hole was, from where that whole big pouch was there, which was the diverticulum, which we had to remove completely and close the bladder. This child has done well post-operatively, there is no problem. He has stopped coming back to me because I said, you don't have a problem. Urethral valves, these are in the urethra of a male child. It does not occur in females. It always occurs in male children. And usually there is an obstruction somewhere here. So when we do an MCU, what we see is an abnormal shaped bladder. There may be reflux. In this case there is no reflux. In this case both sides massive grade 5 reflux is there. This is not bladder. This is the dilated urethra, and this is where the obstruction will be. In this case also this is where the obstruction was, in the form of flaps or valves, which when the child attempts to pass urine, it obstructs. So it dilates, it hits back pressure here, and in this case it has caused bilateral reflux. Now in this case what we need to do is the real treatment. Now this was a child at 15 days, he had gross hydronephrosis both sides with outlet obstruction. Obviously it was posterior urethral valves. We have these very tiny scopes which can go into the urethra of the child, of a newborn. We can go into the penis of the newborn, go inside, and you can see the valves. The valves look something like this, and we have to cut them here, 3-4 places, because that has caused the narrowing of the whole urethra. Once we cut it, the urethral obstruction goes away and the child is able to pass urine. The back pressure goes away. Once the back pressure goes away, see the difference. This was before, where it was hugely dilated, and this is afterwards, when we had done a good job. The whole back pressure went down, so the dilatation, the hydronephrosis was away, and therefore we were able to. Not all children are lucky. Some of them, in spite of doing it at the right time, may still do badly. Sometimes just doing a fulguration may not be adequate. We may have to do more procedures. The point is, earlier you catch, earlier you intervene, better probably are going to be the results. But to catch it early, you need to diagnose it early. Now why do all these problems occur is because urinary infections are treated like cough and cold. Nobody bothers to really follow it up. There are no follow-up investigations. Minor urinary complaints are ignored. If the child says, I am getting burning, bola chal natak kar rahe. So don't ignore them. Proper examination is not done. Very often on examination, like the first case I told you, distension, I found a lump. The mother and father had not realized it. Relevant investigations, as I said, not all the investigations need to be done in all the cases. is the relevant investigations, and parents also. Right now there is a big issue about unnecessary tests being done. Now, which I am not against doing unnecessary tests. I am sure that nobody will disagree with you. But what do you call unnecessary tests? Like in these children whom I have shown, if you ask 5 people, they will say, why are you doing ultrasound and all these things for this small child for a urinary infection? They are not going to accept कि अरे खामखा आपका डॉक्टर बोल रहा है कि you get a MCU done, you get an ultrasound done. No need, he is all right now. Stop doing tests. Don't go to a different doctor. That is the problem. So the parents also don't want, no, doctor, you are going to put a catheter into my child's urethra and then do X-ray and all these things. He is all right. His urinary infection is perfectly under control. So let's finish it. They do not realize that later on they will regret not doing these tests. And that is why the problems is most, if not the all anomalies are present from birth. All these, whether it is duplication, partial, complete, whether it is posterior urethral valves, whether it is hydronephrosis, whether it is vesico-ureteral reflux, all these are present from before birth. And therefore, if you pick it up at 8 years, that means you are 8 years late. If you pick it up at 4 years, you are still 4 years late. If you pick it up at 1 year, you are 1 year late. So therefore, they can result in complications and loss of function on one or both sides. They could have been avoided if they had been picked up early, and could have been picked up if prenatal sonography is made compulsory. Now you imagine if each and every pregnant lady is made to undergo what we call a fetal anomaly scanning at around 18 to 20 weeks once at 30 weeks, because sometimes what is normal before 20 weeks, it may be seen at 32 weeks. Not that we are going to say now you get rid of the child or you need to operate on this child just now. But we are prepared when the child is born, we can go in, intervene, do what the best that we can, rather than wait for the complication to occur and then they will present with gross urinary infection, with infection of the kidney, and then we say, sorry, we will give you antibiotics, but I don't know how much damage has already been done. And therefore I think that we must be very careful about all these urinary complaints, especially in children. Do not ignore them. Do not, say let's just treat it and forget about it. You must have a follow-up, whether it is your pediatrician, whether it is your family doctor, or whether it is you come to people like us, where somebody tells you, please go and refer to a pediatric urologist, who will be probably the best person who may be able to tell you. This is the reason why, because I have shown you the problems which occur, and I think you will agree with me that these are important ones which have to be picked up early. Thank you.